of cavity volume. An early adopter of progressive pneumoperitoneum, Dr. Johnson, published in 1972, something that he believes that abdominal viscera stay in such a long time out, they lose the right to belong inside of the abdominal cavity. Whatever it is, but the anatomical and functional changes were already known to Jean Rief in 1973. He called it eventration disease. Muscle that retracts laterally, hernia enlarges, disuse atrophy, irreversible muscular fibrosis, strap muscles get shorter and thicker, the intra-abdominal pressure lowers, that causes descent of diaphragm and respiratory dysfunction. The mesenteric and bowel wall edema causes increase of the content, and the unsupported spine causes chronic back pain. Also, Parker was right when he called his paper what exactly is meant by the loss of domain. He wanted to find out the definitions. He found 1/3 had a written definition, but 2/3 used the word of loss of domain as a concept without any definition. And only 1/4 used volumetric definition. We will hear from Eduardo Tanaka afterwards. I will leave it here. Of course, that the cutoff threshold or percentage proportion above which loss of domain becomes clinically significant is of importance. This is what we would like to have. Well, Samuel Parker used another 19 surgeons as experts in a Delphi consensus and found out a definition which is, in my eyes, not much better than anything which was said before, but a ventral hernia large enough that the fascial closure either cannot be achieved without additional reconstructive techniques, or it cannot be achieved without significant risk of complications due to the raised intra-abdominal pressure. Why are we so concerned about the loss of domain? Well, the primary closure can cause intra-abdominal hypertension and abdominal compartment syndrome. The World Society of the ACS, that I had no notice about until I prepared this topic, demonstrates very nicely with increasing intra-abdominal pressure rises the mortality of the patients. Substantial loss of domain causes recurrences, and there is no consensus until now on the loss of domain threshold predicting postoperative failure. So what are the lessons that we've learned from the past? We have several ways how to reduce the risk of ACS. And today I may add one more. We will hear about it later in the session 3, the perioperative expansion of abdominal wall called fascial TENS. And if I ask our captain what he sees on the horizon, he would say, yeah, fine, it will be a good content. But humble myself, I would say today will become historical. And I wish you all a great conference. And donate the next 30 seconds to the next speaker.
Thank you very much, Jan. It was breathtaking. It was actually, you've done your homework very, very well, haven't you? It was very nice. I think Friedrich Kalinowski is going to be very happy for the donated 30 seconds. It's a person that I think deserves a little introduction because he is not probably as chronically known as many of the other surgeons around the globe who dedicate their effort and time to abdominal wall repair. But Friedrich is very unique. And I remember a few years ago, I tried to publish a study which was talking about some very basic physics. And so many journals have turned my article down because they said it's not interesting, it's not important, and it's hard to understand. And he was the person who actually grabbed my hand at one conference and he said, I read your paper, it was actually interesting. And since then, I have heard his talks a few times, and I must say he is able to present these physical principles and all the things that I believe all surgeons should understand and should have very good knowledge about in a way that everybody can understand it. He's done a much better job than myself, and I would like to ask him to talk about the biomechanics of the abdominal wall. Thank you.
Thank you very much, Barbara. Thank you very much, Jan. I think I tried to share my screen. I hope I did it right.
Yes, it does.
And so we talk about durable mesh repair. I thank Ramana for inviting me to have me here. And I thank all the participants to listen, because it took me almost 30 years as a surgeon to understand that biomechanics is the basis of what we do. And to do a loss of domain repair durably requires some knowledge. And so we do 5 slides on a bench test. We do 4 slides on computer tomography of the abdomen with Valsalva's maneuver. And then we do some clinical strategy and some results. The results are from a register. Ferdinand Köckerling opened a new page in the Hernia Med registry, and it's called Stronghold. It's 10 hospitals donating patients to this. And I want to thank Markus Büchler, head of the Department of Surgery, who supports this since 5 years now. So here you can see the bench test working. It was built in Hamburg with the Technical University, thanks to Michael Morlock and Matthias Vollmer. And it pushes like coughs, 1 second push, 3 seconds relaxation. And you see what happens. The energy going into the system moves the tissue and the mesh differently. It depends on the characteristics of the tissue and on the characteristics of the mesh. And you can calculate from the data you obtain what you need to do, the critical resistance or retention force. And you can see the gained resistance of impacts related to pressure. What have I actually achieved during my repair? And the first thing you want to know, what is actually the retention force of my mesh? So people call this the tackiness. You know, the tackiness of meshes can be classified by this bench test. Since we do not do a full cough, we call it dynamic impact strain. And if any reconstruction holds more than 400 of these impacts in 10 repeated experiments with different tissue types, you know, there are pig tissues and there are bovine tissues, and these tissues come from different animals. And so we have all kinds of trained animals walking around and lazy animals always standing. And so it's a variation. And if it holds 4,250 of these impacts, we believe it's a fairly good retaining mesh. And so it gets a factor or a coefficient of 1 or better, and we call it a disc class A mesh. And the other meshes, they fall behind. And the mesh with the lowest retention force was withdrawn from the market since it had high recurrence rates in the registries. So we believe this is a guidance. What does the mesh do? And in order to get a handle on a calculation, we used the proposal by Tullo and de Bow. They proposed you use the mesh defect area ratio. And this is for a round mesh and a round defect, but you can calculate it for any sort of kind of defects and any sort of kind of meshes. So you can get a mesh defect area ratio as a figure. And if you multiply this or add influences to it, you get a grip factor, which is the gained resistance of impacts related to pressure. So this grip factor, you calculate as the mesh defect area ratio times the mesh factor times a bonding factor for fixation, a position factor for wherever you put the mesh, underlay, sublay, IPOM, onlay, and a closing factor and other factors as well. And it's published data, and you can look it up and figure out. Otherwise, you give me a call, you get my phone number later. So when you want to calculate what you need, you must recognize that with increasing hernia sizes, you need to have higher grip values. And this line here is called the critical resistance. If you are surpassing this critical resistance, you are in the green area here. You will have an adequate grip. And if you are not surpassing this resistance, the critical resistance, you have too low a grip. I mean, if you have a patient who is not coughing or not walking around or has no other risk factors, maybe this grip is okay, but you have a higher risk of dislocation and recurrence if you have an inadequate grip. And if you have an adequate grip, you reduce this. So you can calculate it, you can adjust it to the tissue stretchability, which we will talk about 2 slides from now, and you can adjust it to the tackiness of the mesh and to other factors as well. Another point is the defect closure, and these are 2 clever students from our lab, and they did an extensive study of what you have to do a defect closure durably, and you can suture defects up to 7 centimeters. If you have a no mistake strategy, you mean you have to do a flawless suture. With a stretchable suture, you use a small stitch, more small bite approach, and your suture tension should be in some area range, fairly low, and the incision to suture ratio should be at least 1 to 4.4. So, and then all defects were held tight against these 4,250 pulse loads. So if you do not have this kind of strategy, or you are uncertain about it, you should use a sandwich reconstruction technique. We talk about it in a minute. Next thing, abdomen computer tomography with Valsalva's maneuver. People have been looking at the hernia sac, and this is where the definition of loss of domain is coming from. And as you do a Valsalva, the hernia sac extends and pushes forward. But we look at the abdominal wall, and in this guy, a 42-year-old guy with a recurrence after IPOM for a fairly small hernia defect, about 2 centimeters, 1 year later, he had this kind of opening, 10 centimeter opening, and it stayed almost stable during Valsalva. So he has a stable abdominal wall here with those circles. But if you have an unstable abdominal wall, you will have much more variation in those, and you have to analyze more carefully. You have to do at least 12 assessments, and this costs you about 45 minutes to 1 hour of manpower. So we looked for better ways to do this, and we used artificial intelligence and picture analysis. And with artificial intelligence, you can see here an unstable abdominal wall. The defect is the red area. The rectus muscles are the blue shaded ones. And as you push, the abdomen opens. It's a person, 57-year-old, with repeated incisions, short bowel syndrome, and the defect almost triples during this procedure because a new defect opens. So this is one thing. Defect area increases with an unstable abdominal wall. And the other thing is you get notches and stress concentrations. If you have a mesh in this guy, 30 centimeter wide and 45 centimeter long, you will still have distortions at the edge, and you need to close these with good fixation. So this is what you get from this analysis. And in the broader spectrum, the healthy abdominal wall has a strain of about 1 to 1.5 centimeter, and the herniated abdominal wall has a strain of more than this, 90%, 6 centimeters. And if you have a loss of domain, you have strains of 10, 12, and 14, 18 centimeters. And if you do a progressive pneumoperitoneum, you reduce it to lower values. So you reduce the strain with a progressive pneumoperitoneum. I believe the same is true for Botox. So the next thing is, what is our strategy? First, use the computer tomography to assess the abdominal wall, and then maybe use Botox or progressive pneumoperitoneum. Then think about how to create large enough a space to put your mesh in. Use a disc glass A mesh if possible, or adequate fixation. And if you cannot close the defect or have other problems, you can build a sandwich. And for the skin and skin and subcutaneous defect, you can use an advancement flap. And this advancement flap closes it. And I think you should resect the umbilicus to reduce contamination. So what are the results of this? It's not all loss of domain patients in here. It's 1 year results. You have no recurrence, no chronic pain in this group from 4 hospitals, and all patients which were below 62 years old returned to work. So thank you very much for your attention.
Friedrich, thank you very much. Another star lecture, and clearly a lot of work we need to do in assessing our patients in addition to clinical examination. But moving on swiftly, it's a great pleasure to introduce a fellow European, Johan, who's really, I guess, a disciple of some of our old European stars, Professor Clement, Chevreul himself. So it's an absolute pleasure for Johan to talk to us all things anatomy relating to loss of domain. Johan.
Thank you, Andrew. Dear friends, dear Dr. Ramana, congratulations for the organization of this event, and thank you for this opportunity to speak about structural and anatomical changes in loss of domain. First, remember the different definition of loss of domain published in 2014 by the EHS, in 2016 by the French, and in 2020 by Delphi Consensus. This definition seems the best. An incisional hernia with loss of domain is first too large and then too voluminous, with high risk of postoperative hyperpressure after the repair. So we will try today to explain these difficulties in an anatomical point of view. But it is really difficult to draw general conclusions because a loss of domain is always different among patients in terms of size, location, with patients suffering in age, weight, tissue quality, and wounds are all different with several different comorbidities, as you can see among this drawing with all these patients. So for the reason, it is very difficult or impossible to make general statements, but we will try today to explain these difficulties in terms of anatomical changes. One more slide with several patients explaining that they are all different in terms of anatomical changes. Here is the summary of this presentation. We will first see how the loss of domain implies changes in the abdominal wall muscles and how it interferes with the motricity. Then we will see the changes in the abdominal pressure, in the respiratory functions. Then we can see the local changes and the visceral changes. So using these 5 points, we will explain how the process is complex and how the treatment is difficult. I have to see that all these considerations have been already explained since long time, in particular by Jean-Rive and colleagues from Reims here in France. First, the musculature and the trunk motricity. The muscles are a complex dynamic cylinder inserted on the lower wall of the thorax superiorly and on the upper edge of the pelvis inferiorly. So we can see relative and opposite movement of the thorax in relation to the pelvis, giving the inclination, the rotation, and the flexion. Hence, the motricity and the mobility of the spine comes from the contraction of the abdominal muscles, and the spinal muscles posteriorly are the opposite muscles giving the extension. Second, there is a torque of tension. The muscles are a dynamic system under tension inserted in the linea alba in the middle, and they give divergent traction of this torque of tension with opposite action of each side. So the linea alba should be intact for correct dynamic mechanical system. Knowing this concept, what are the consequences of a division of the linea alba during loss of domain? There is a rupture of this medial tendon with anterior disinsertion of muscles. And we can see first a sagittalization of the rectus abdominis muscle as it was drawn using this original drawing of Reeve. And as you can see on these two slices of CT scan on this patient. This sagittalization is very important during loss of domain. Second, we can see a retraction of the lateral muscles. As you can see here, the muscles are retracted in posterior part of the abdomen. Third, due to this retraction, we can see an atrophy and fibrosis of the lateral muscle. It has been shown already in 27 with a muscular degeneration, sclerosis. The muscles are stiffer and less elastic in the posterior. In fact, there is three areas to explain this atrophy. Superiorly, the muscles insert on the ribs cartilage with short fibers, so here the retraction and atrophy is irreversible. In the inferior part of the abdomen, there is no muscular fibers since the muscles are made of large aponeurosis part, and this part is not concerned by the retraction and atrophy. The important is in the mid-level, the muscles are inserting in the spine with long fibers, and here in the middle, the retraction and the atrophy is partially recoverable. We can say that strap muscle fibers become shorter and thicker. Fourth, we can see back pain because there is this muscle retraction and atrophy. There is the sagittalization of rectus muscle and a diastasis of rectus muscle. So there is a spinal counterbalance to move the abdomen with spinal deformity and chronic lumbar pain. And fifth, there is an increase in the volume. Thanks to Pascal's principle and due to intra-abdominal pressure, there is a traction of the lateral muscle and the diastasis increase. So Reeve called that an open double door. The hernia gradually enlarges, giving a second abdomen. So to conclude about the muscles, in case of loss of domain, we have a sagittalization of the rectus abdominis muscle with retraction of these lateral muscles that became atrophic and fibrotic, giving some changes in the abdominal wall motricity with back pain, explaining the progressive increase in the loss of domain volume. The second important thing comes from the lung function and respiratory function. Normally, there is a synergic action between the abdominal wall and the diaphragm. During the inspiration, there is the contraction of the diaphragm and the relaxation of the abdominal muscles. And during the expiration, there is a relaxation of the diaphragm, and in case of effort, the lateral muscles become the main expiratory muscles. So the lateral muscles regulate the intra-abdominal pressure. But in case of loss of domain, there is the retraction of the lateral muscles and the viscera are out of the abdominal cavity. So there is a significant reduction of the intra-abdominal pressure. For this reason, there is a diaphragmatic descent with a progressive flaccid paralysis of the diaphragm, giving a respiratory dysfunction with a restrictive lung disease with a total lung capacity inferior to 80%. This thing has been explained by Reeve as a paradoxical respiration. During the inspiration, normally the diaphragm moves down and there is a counter pressure from the abdominal muscle. But in case of loss of domain, the incisional hernia inflates during the inspiration. During expiration, normally the diaphragm relaxes and the abdominal wall inflates. But in case of loss of domain, during the expiration, the incisional hernia reintegrates the abdominal cavity. It is the paradoxical respiration, giving a restricting lung disease getting worse. And this thing can be explained with this patient when he coughs, the incisional hernia inflates, but normally it should reintegrate the abdominal wall cavity. So we have seen the muscular changes, the changes in respiratory function, and changes in intra-abdominal wall pressure. Now, what are the local anatomical changes? During loss of domain, the skin getting very thin, with chronic ischemia of the skin and the risk of trophic ulcer. Moreover, the omentum can be infected with the risk of intertrigo microabscesses. So during loss of domain, there is a high infectious risk explained by the anatomical changes. And as you can see on these small drawings. And lastly, what are the visceral changes? During loss of domain, there is an important circulatory disease. Due to low abdominal pressure, there are a portal venous stasis and a potential risk of thrombosis. For this reason, there are a mesenteric and bowel edema with congested bowel, and that give an enlargement of the viscera become heavier. It is called as a splachnomegaly that can give diarrhea and abdominal pain, and that makes the reduction even more challenging. This protrusion of visceral content can be here shown on these three patients with a high splachnomegaly, as you can see here, due to the edema of the bowels, making the reduction very difficult. So to summarize, what are the anatomical changes during loss of domain, why it is so difficult to treat, and what are the solutions? First, concerning the abdominal wall muscles, we can see the sagittalization of the rectus abdominis muscle, the retraction of the lateral muscle, and the atrophy of this lateral muscle. First, that explains why the Botox may help, because it plays a role against the retractation of the muscles. And second, that explains that for us, the ideal treatment is the complete closure of the abdominal wall, the reinsertion of the lateral muscles in the midline, and the restoration of a functional abdominal wall. And that explains that the Reeves technique may be the gold standard for incisional hernia, because this technique implies the frontalization of the rectus muscle in the midline. Second, concerning the changes in the abdominal pressure and the risk of progressive increase in the volume, the ideal management is a prior evaluation of the loss of domain with the calculation of the volumes to anticipate the postoperative hyperpressure. Third, concerning the respiratory function, there is a high risk of postoperative respiratory failure, and the solution to enlarge the abdominal cavity are the Botox, the component separation, and the preoperative pneumoperitoneum. And in Reims, we use always the preoperative pneumoperitoneum because it plays a role, again, the diaphragmatic descent, because it is a preoperative rehabilitation of the diaphragm. And finally, concerning the local changes with the risk of trophic ulcer and the visceral changes with the splachnomegaly, a wound healing is necessary, and the weight loss play a role against the splachnomegaly. To conclude, during loss of domain, there is structural and anatomical changes that have been already explained years ago by Reeve in Reims and colleagues, with the decrease of the intra-abdominal pressure and consequences, the risk of respiratory failure, the visceral and vascular changes, and the static changes. So the incisional hernia disease, as called by Reeve, is very challenging. It is not only a defect to close. Thank you very much for your attention. Dear friends, dear Dr. Ramana.
Thanks very much. Johan. I hand over to Roshi to introduce the last speaker.
Okay, thank you very much. The last speaker, that's Professor Eduardo Tanaka from Department of General Surgery, Hospital das Clínicas, University of Sao.
Well,
Reported. Can you hear me?
Yes,
Yes, I can.
Yes, we can hear you well.
Okay, sorry. He came up with and first reported the famous Tanaka index and is a leading expert in loss of domain treatment in not only Brazil, but worldwide. Professor Tanaka, are you ready?
Yes.
Okay, his presentation title is What is Loss of Domain? If you're ready, could you please start your presentation?
And starting my presentation. Good morning for everybody. And my name is Eduardo Tanaka, and I'm talking from São Paulo, Brazil. And I'd like to thank the organizing committee for the invitation, especially Dr. Rodrigo Galego and Dr. Ramana for the invitation. In behalf of Brazilian Hernia Society and the Abdominal Wall and Hernia Reconstruction Group at Hospital das Clínicas of Sao Paulo. I will start my sharing my presentation, and I will talk about and try to answer what loss of domain means. For the ones who doesn't know our hospital, this is a picture of the hospital complex that is the biggest public healthcare system in the Latin America. I have no conflict of interest and have no disclosure. These are two examples of two patients with giant incisional hernias with loss of domain that we are going to talk today. So what is a loss of domain? There are patients with a second hernia that behave like a second abdomen. There are large hernias with a large part of the abdominal content outside of the abdomen, inside of the hernia. Loss of domain means that there is a large irreducible hernia. Means that we have a shrinkage of the abdominal continent, and the viscera lost the right of domain side of it. Yeah, I can say that it's a little bit of everything together. So how can we answer this question? So lots of specialists has a lot of different definitions, and the two authors had the same question. Parkin and Halligan described this article and making a systematic review for the definition of loss of domain, because this definition is important, because the treatment of the patients with this kind of hernia leads to serious physiological complications, and identifying it and adequate treatment may avoid undesired results and disastrous catastrophes. Loss of domain may increase the intra-abdominal pressure when correction, and in extreme cases lead to abdominal compartment syndrome. The treatment may have increased wound complications if there are no special attention to the soft tissue above hernias, and may lead to more hernia recurrence. So it's crucial to identify those patients because loss of domain may have a prognostic value. And these patients may be aware to preoperative management and improvement of their conditions. So the contents of the hernia sac lost the right of domain inside the abdominal cavity. And those patients has a shrinkage, thickening, and contraction of abdominal wall that leads to a reduction of abdominal volume. And the aim of all hernia treatment is return of the hernia content back into the abdominal cavity and reach adequate reconstruction of abdominal wall. So, is it possible? Always. We have to think, even the surgeon has this kind of doubt, and in which cases is it impossible? So there are some tools that we can use to answer this question. And so one of the tools are the CT scan and the volume calculation. So to define loss of domain, the same authors, Parker and Halligan, joined 20 expert surgeons in abdominal wall reconstruction and tried to make a international Delphi consensus, trying to reach a definition for loss of domain. So the first written definition was achieved, and the written definition is a ventral hernia large enough such that simple reduction in its contents and primary fascial closure either cannot be achieved without additional reconstructive techniques or cannot be achieved without significant risk of complications due to raised abdominal intra-abdominal pressure. So it's big, broad classification and definition. And the second aim of the study was make a volumetric definition by Delphi consensus. And they analyzed two methods that make a volume calculation. One of them is our method, Tanaka method, and the other method is Sabag method. For those who doesn't know us, and these are simple explanation about it. So we have the abdominal content and the hernia content. The Sabag uses total peritoneal volume, that is a sum of abdominal cavity volume plus hernia sac volume. And the loss of domain is defined when there is a hernia sac volume divided by total peritoneal volume greater than 20%. In our method, we divide the volume ratio is reached dividing hernia sac volume by abdominal cavity volume, and the loss of domain is defined when the volume ratio is greater than 25%. So the Sabag method was described in 2011, and he uses, they use special software to reconstructive calculation of the volumes of the incisional hernia and the abdominal cavity. So the ratio is above 20%. Our method was described in 2010. We don't use any computer software, and we compare the hernia and the abdominal cavity with two ellipsoid forms, and then we use the mathematical formula to calculate the ellipsoid. So both hernia sac volume and abdominal cavity volume are multiplications of the largest diameters of each cavity, anterior, posterior, lateral, lateral, and craniocaudal diameters, multiplied by 0.52. These are a picture showing the lateral diameters of the abdominal cavity and the hernia sac, anterior, posterior diameter of the abdominal cavity and the hernia sac, and the craniocaudal diameter of the abdominal cavity and the hernia sac. And we classify as hernias with loss of domain that are greater, the volume ratio is greater than 25%. Unfortunately, the Delphi consensus chose the Sabag method for the volume calculation. But they tried to reach also the volume ratio for loss of domain threshold, but there was no consensus about it. This was a shame because this cutoff, this threshold is the key for, in our opinion, for the adequate treatment of these patients. The Fafage author published in June this year in 2021 at JACS, this article named "Can Hernia Sac to Abdominal Cavity Volume Ratio Predict Fascial Closure Rate?" using our score, the next score. So why he choose our method? Because of its practicality, and other methods use a CT scan and a special software and needs a radiologist specialist to volume calculation that is not always available for it. And our method is relatively quickly done by a surgeon that has basic knowledge of CT imaging. More importantly, it can be done anywhere, even in the seeing the exam in the computer, so it can be used daily basis in the daily practice. So in conclusion, the authors conclude that the VR cutoff of less than 25% has a great result predicting the complete fascial closure. That is the same experience that we have in our service, because all the patients that has volume ratio less than 25% doesn't need any augmentation technique and goes directly for the surgical abdominal wall reconstruction and doesn't need any special key for accomplish the aim of complete fascial closure and abdominal wall reconstruction. So This is our algorithm for the treatment of the patients. All patients that has big hernia with suspicions of loss of domain are submitted to CT scan, and all the patients with volume ratio less than 25% go directly to surgery with complete fascial closure. And we always use onlay technique. Intraoperative intra-abdominal pressure monitoring is not necessary in these cases, and we almost always achieve abdominal wall reconstruction. In the patients that has volume ratio bigger than 25%, some methods of abdominal augmentation may be needed, as preoperative pneumoperitoneum, or other chemical augmentations like Botox, or even abdominal content reduction, like, for example, bariatric surgery if BMI bigger than 35 and the patient has comorbidities, or BMI larger than 40%. And those patients are then submitted to surgery with aims complete fascial closure. In intraoperative abdominal pressure is monitored and to avoid intra-abdominal hypertension or even abdominal compartment syndrome. If there is any suspicions or elevation of the pressure, other techniques of surgical augmentation of the abdominal cavity are done, or in extreme cases, well, visceral reduction are done to reach complete fascial closure and correction of abdominal wall, reconstruction of abdominal wall. I should highlight that since we have used bariatric surgery perioperatively, none of the patients needed visceral reduction, and all patients had completed abdominal reconstruction adequately, not needed bridging or any other surgical bridge or something. So these are examples of patients that we have treated successfully. Thank you. This is my email for any.
Thank you very much, Dr. Tanaka. Are there any discussion time?
I think
Yeah, we have about
minutes.
8 minutes for discussion. Yeah.
There is no question in the chat box.
Well, let's kick off some questions. Frederick, I have a question for you, and that was your very interesting description